Good evening, everyone. So, I'll be speaking, of course, for the favoring late for DBS management, DBS in the management of Parkinson's disease. As we all know, DBS, it's an established therapy as a part of the treatment guidelines for the management of advanced Parkinson's disease with severe motor fluctuations and dyskinesia that cannot be adequately managed by medical treatment worldwide. That's a standard thing. There's nothing new about that, right? We all know that. And apart from Parkinson's disease, there are various other applications of DBS as well, right? And this is a timeline of how, since the inception of DBS to the various technological advances like directional DBS and adaptive DBS, which we'll all see in near future. So DBS, first of all, is not a neuroprotective therapy. It improves, of course, the symptoms and quality of life. So don't just spend into early surgery. It improves the symptoms and quality of life, but it doesn't stop the neurodegeneration. So it's a powerful symptomatic therapy, but not disease modifying. So the most scientific timing is when disabilities from fluctuations, dyskinesias, it's proven and meaningful, not just merely early, right? So merely early is not something that you are offering your patients to. Now, there are various papers which prove that the disease progression continues despite bilateral ST and DBS. So it's the effect of the ST and DBS seems to have no effect on the rate of disease progression or the process responsible for neurodegeneration. So these studies confirm that neuroprotective properties of DBS was not proven. Whatever we have, that's a preclinical evidence, right? Based out of animal models and rodental experiences, right? So there's no clear evidence for ST and DBS related neuroprotection, which is still missing. So you cannot just hang your hat on that concept. Then apart from that, we have a lot of various RCTs based on late DBS, which has got strongest evidence how it improves quality of life and motor benefit versus best medical therapy. So definitely DBS wins most clearly when the disease is advanced enough that benefits outweigh surgical risk. So one has to maximize benefit to risk ratio. So operate only when the ethical sweet spot is there, when motor complications clearly impair the quality of life of the patient and expected gain is substantial. So clinically meaningful quality of life is very important. Now this was a trial, a German study where they looked into the DBS and for PD, where they clearly showed that advanced DBS really helped in improving the quality of life of these patients, but what at the cost of serious adverse events. So serious adverse events were always there. However, it led to improvement in the quality of life of such patients. So we have n number of trials where when DBS, when contemplated in the later stage or advanced stage, it helped our patients, not only just improving motor part as well, but also the other part as well, like quality of life and so on. Now, late DBS, on the other hand, aligns with pragmatic trial evidence that the later stage indication when complications dominate. Of course, we need to take into consideration the risk of the surgery, early surgery that we are putting when we are considering early surgery. So there also it favors late DBS. Now, this was one more study where they looked into early stage DBS, which again found no evidence of improvement in motor symptoms as well as quality of life when they consider early DBS, like those patients with less than 4 years of disease onset. So again, so this was the thing. Then early DBS is narrowly generalizable, what my colleague was quoting as early STIM trial. So early DBS evidence is not DBS for everyone early. Each case is different, each case has to be individualized, right? Might be useful for selected young subgroup, that fact I'm not denying, but why expose an early stage working patient to higher adverse effects risk before they actually need it? We need to justify benefit and risk ratio at the same time. So early motor complication trial like early STIM showed serious adverse effects in the DBS group, like 68 of 124 patients versus 56. So 54% in the neurostimulation group versus 44% had severe surgical or device related complications. Also, we need to consider other aspects like non-zero surgical risk plus no disease modification and potential so-called placebo-ness placebo effect and highly motivated participants in the early STIM trial. So early DBS evidence applies to a selected niche, not an average PD patient. So what we are talking about is our Indian PD patients who are not always early young PD, those classy patients. So, and not newly diagnosed PD as always. So this is an early STIM trial where they looked into early DBS, where most of the patients were 52 years of age group or less than that, and most of them had motor fluctuations of less than 2 years. Here also they found that though quality of life improvement, motor improvement was there, but there were serious adverse events related to neurostimulation group versus best medical therapy. So that point we cannot just negate, even in the best of the surgical team, even in the best of the care, right? Or you can see here. And on the top of it, it was found that pilot study in patients with early PD concluded on the same percentage of improvement in the quality of life when they looked at the patients who had undergone late or advanced PD surgery or DBS surgery. And this is a comparison of various RCTs which was showing that early STIM was the only trial in which the patient age group was almost 52 and disease duration was very short out of all other trials. So there were some of the drawbacks of the early STIM trial as well. Now, CAPSID PD, here they have suggested at least 5 years of disease duration, and early STIM they took into account at least 4 years of disease duration. But are these years sufficient enough to exclude atypical Parkinsonism? What about levodopa responsive PSP, MSAP that may mimic PD for years together, motor fluctuations and dyskinesias? I can show you n number of evidence for that. So here, this was a study where they looked at early onset PSPs, and they mimicked the PD, at least in the early phase, where they had Parkinsonism, gait freezing, and almost half of them were initially misdiagnosed as having PD by qualified neurologists and movement disorder specialists. In this study this was autopsy-proven MSA study, where they found almost 18 to 20% of the patients were having alternative diagnosis of PD or PSP. So this is one more study where they found that patients of MSA, they had mean disease duration of almost 11 years. And they also had levodopa-induced dyskinesia that we classically see in our EPD patients. So we need to be aware that MSAP can occasionally have benign course, and it could be difficult to distinguish. And these stringent criteria of 4 years and 5 years of early may not be sufficient enough to put them to the surgical risk of DBS. Young onset MSA patients could have levodopa-induced dyskinesias, dystonias, and they could mimic young onset PD as well. So that is very important concept. And also this paper showed that it has to be, they suggest that one has to be very careful and attention should be given to the possibility of young onset MSA before you screen these patients for DBS, early DBS candidates. So dear friends and colleagues, let me ask you, can you afford to miss these cases of atypical Parkinsonism? Guidelines from various evidences like EAN and other invasive therapies guidelines also explicitly suggest that invasive therapies are generally reserved for specific patient groups. Like over here, they don't recommend early PD without motor fluctuations, these patients to undergo deep brain stimulation. So you can see from the guidelines as well. And so they clearly mention that do not offer DBS to those patients with early PD without fluctuations. So even the guidelines also say that don't rush to DBS. This is select the right patient at the right time. And the right time would be different for each individual because each PD patient is different. PD is, as we know, it's heterogeneous. And rate of disease progression is also variable. So it may so happen that we might offer DBS to those patients whose motor fluctuations may remain mild for longer duration, like mild benign PD. Or on the contrary, there could be some patients who would have rapid development of DBS non-responsive symptoms after surgery. And they feel that I'm not responding to DBS. Doctor, what have you offered me? So that is that. The PD with early motor fluctuations can still be well controlled with medications. And in early STIM trial, which my colleague was pointing to, there was a smaller non-significant quality of life improvement at 2 years when they compared with other trials when the patients had undergone advanced stage surgeries. Now, other factors that we need to take into account is disease heterogeneity, consideration of non-motor and axial symptoms, and each case has to be considered. One size doesn't fit all. Patient's age, phenotype, their needs and expectations has to be looked into account as well. And there is no evidence that dementia, hallucinations, falls or autonomic disturbances, nursing home placement can be postponed by early surgery. So this was a viewpoint where they clearly mentioned that ST and DBS should be offered when there is a favorable clinical benefit to risk ratio, rather than routinely considering it at the onset of motor complications. And there are specific challenges that one needs to envisage before putting them to the risk of early DBS surgery. So inclusion of patients with atypical Parkinsonism, that I already discussed that point, right, which were missed, some of the patients were missed in early STIM trial. Does DBS at low threshold have less potential for improvement? What about the floor effect? Benefit to risk ratio in patients undergoing ST and DBS just after the onset of motor complication could be less compared to those with greater preoperative disability from motor complications. DBS may be unnecessary in patients with a milder course of PD, and early surgery will again put these patients into more years of implanted device, as well as higher probability of lid fractures, malfunctioning or ICH and infection and so on. So these were again a few randomized controlled trials which suggested that early DBS has higher serious adverse events incidence as compared to medicines. So late DBS, better risk benefit math. DBS too early can mean many more years lived with extra device burden, which some patients might not be accepted to. And on the top of it, various programming visits, troubleshooting, lid battery issues, infections, we need to take into account those things as well. So this was a randomized control, this was a trial which looked at various meta-analysis, and they finally concluded that the primary outcomes of all mortality, serious adverse events and everything was taken into account, and they concluded that compared with only anti-Parkinson drug therapy, neurostimulation, that is DBS, with drugs seem to increase the risk of various adverse events because of perioperative complications and hardware related complications. So there is the strongest RCT based evidence that in advanced PD with troublesome fluctuations, it should be offered. When even in the best of the trials, benefit comes with real surgical or device risk. Come on, we have to be realistic when we are offering or when we are explaining about the risk and benefit to the patients. And real world sweet spot often looks like mid duration, not as early as possible, right? So even newer synthesis suggests that maximum gain zone is in the mid stage, is not supporting the early stage. And so this was again the one trial which concluded that with patients with advanced PD, DBS was more effective than best medical therapy, and but however it was associated with increased risk of serious adverse events. And also in early STIM trial, so there were patients who had positive expectation of the benefit in the surgical arm who underwent ST and DBS. So that was a placebo effect. And we all know that the in PD almost 7 to 40% would have this kind of placebo effect as compared to the best medical therapy, which would have negative expectation of the response, which is known as placebo. So that could have also implicated somewhere or reflected in the results of early STIM trial. And the quality of life and beneficiaries. So the best predictor of DBS benefit is patient perceived quality of life. So it is that waiting until quality of life is clearly affected is scientifically aligned with selecting those who benefit most. So larger quality of life gains in moderate to advanced PD patients with motor fluctuations. I'm just going to be concluding. Sure. So this was shown here, that effect of ST and DBS on motor symptoms and potential effects on disease progression. Here also they could find that if you are putting that patients in the early stage, they are in the levodopa honeymoon phase. So better we offer them in the moderate stage or late stage before it is too late. So careful selection of the patient for DBS is the key. We need to also consider genetics, which would influence the DBS outcomes. Like patients with heterozygous GBA mutations, they are considered to have increased risk and modify the PD phenotype. Early stage indication, we should not be hasty in making the decisions. And associated comorbidities like increased mortality and rates of readmission post DBS, and of course role of heterogeneity. So this is the slide showing outcome of DBS stratified according to various genetic modifiers. Now, these are the best profile candidates for DBS, like idiopathic PD with disabling motor symptoms, tremor predominant PD, early onset PD with levodopa responsiveness and disabling motor fluctuations, patients with little or no cognitive impairment, motor fluctuations, and despite of optimized medications and high functioning. So this is the ideal patient profile for DBS in PD, and one should be mindful about the contraindications, which sometimes may evolve a little later, like dementia or uncertainty about the diagnosis, higher cardiovascular risk and comorbidities. So friends, in the country like India, late DBS preserves affordability and adherence. So especially in patients with medication refractory, to improve the acceptance, right? So are we really justifying early DBS surgery? We need to take into account this risk, like no effect on the rate of disease progression, cost and surgical risk, dysarthria, gait difficulties, which would be happening in the later stage, risk of subjecting patients with atypical Parkinsonism, PD with motor fluctuations who would be otherwise mild. Some patients of PD phenotype would have faster disease progression and higher genetic burden. That is very important. And finally, what is important is quality and degree of expected benefits, duration of treatment-induced motor complications. Counseling a patient about DBS and age at surgery is only a relative consideration because it is associated with clinical profile of a patient as a whole. So to resolve this challenging puzzle, it has to be an individualized approach rather than talking about early or late DBS. Duration of PD and motor complications, alignment of expectations of the patient and the caregivers, it should be a shared decision making process. So individualization approach is the key, not early or late. Can I have the volume here? There's no volume. Could you hear this? So it is symptomatic high impact therapy, last slide, high impact therapy, and the most scientific timing is when levodopa responsive motor complications clearly impact the quality of life, which may be individual in individual patients despite optimized therapy. Late enough to justify the risk, early enough to avoid too late axial cognitive stage. That's how you maximize the benefit, avoid overtreatment and deliver real world avenues. So in the war of PD armamentarium, the most relevant issue is not when but on whom to operate, and early is not always better. Remember this. It's not about early versus late. It's about premature versus appropriate.
Yes,
Thank you. And that's my case.
Yeah, excellent summing up of the.
Sorry for overshooting a little bit.
No, I think it was a very, very nice talk with covering all the relevant points. Why later than earlier, and whom to operate rather than when to operate is a very, very good point that you made. Thank you.